This is Dr. Pete from AZ Ascend with our in-service about prophylactic antibiotics, part of our series on antibiotic stewardship by an award-winning protocol. So just to put us in the right frame of mind, let's remember that the root cause of widespread antibiotics resistance is people receiving antibiotics for infections they do not actually have. As my friend and colleague Stan Darasinski at Stanford says, we are awash in a sea of antibiotics. And the main culprits for overprescribing of antibiotics are treatment of presumed urinary tract infection, presumed pneumonia, and presumed skin and soft tissue infections, specifically round wounds or pressure wounds. Those are the three culprits that are overtreated mainly. So today we're going to talk about prophylactic antibiotics, which is another way that antibiotics are often overused or ineffectively used. So the intention or the aim of prophylactic antibiotic therapy is to prevent unwanted primary or recurrent bacterial infections. And here it's good to notice that prophylaxis, the dose in prophylaxis, is often a quarter to a half the therapeutic dose for continuous long-term therapy. So if you see somebody on daily small doses of antibiotics that's otherwise familiar, you know for sure they're likely on a prophylactic regimen. So when you talk about prophylactic antibiotics, there are really two kinds of scenarios we should be concerned with. First, there's a scenario where prophylactic antibiotics is evidence-based and good practice. And here the main two to keep in mind are surgical prophylaxis protocols. There are many of them depending on what the site of surgery is. And patients are now often covered with antibiotics during otherwise clean surgery, where you put a clean hole in the belly, to do an excision of a gallbladder or something like that. And the important thing about a prophylaxis, surgical prophylaxis protocol is that the antibiotic must be in the tissue at the time of the skin incision. And only 1 or 2 doses should be given such that the antibiotic is still there at the close of the wound. And after that, no antibiotic is needed. So it's in the tissue at the time of you put a hole in the patient. And it's only there to cover the time that you have a wound open. Once the wound is closed, it's no longer an infection risk. So the practical way that most people do surgical prophylaxis is they get the antibiotic into the patient an hour or 2 prior to surgery. So if it's an oral medication prophylaxis, they take the oral medication the morning of surgery, more than an hour before surgery if you can. And many facilities now do surgical prophylaxis as part of the induction process in the OR. So the anesthesiologist is frequently the one that administers the antibiotic, either on a pre-anesthetic visit or at the time of the patient gets wheeled into the operating room. Usually those are intravenous antibiotic protocols. So that's definitely a well-recognized, and there's a lot of evidence that surgical prophylaxis protocols work to severely decrease or in fact eliminate clean wound surgical infections. The other area where prophylaxis is evidence-based is invasive procedures in immunocompromised patients. For example, a transplant patient, say with a kidney transplant, that's on anti-rejection medications, which makes them immunocompromised. If they have to have a routine procedure like dental surgery or things like a colonoscopy, they should be covered with antibiotics, because if they're not, then occasionally you'll get a roaring sepsis supervening in immunocompromised patients, say because of a little bite biopsy done in a routine colonoscopy, which wouldn't be for normal people like you and I, wouldn't be a concern at all. But in an immunocompromised patient, you have to be very careful about that. So those are prophylactic antibiotic protocols that are evidence-based and not a problem that we're going to talk about further. We're going to talk about a series of the most common myths of prophylaxis, like what is believed by people who are doing prescribings, nurse practitioners or physicians. And they have beliefs that do not stand up. They're not evidence-based. And one of the commonest ones is putting patients on antibiotics to treat or suppress either what's called recurrent UTI or so-called chronic UTI. And these situations usually do not meet the case definition for a UTI, and people end up treating mainly bacteriuria only. And remember, by our protocol, even if you have a colony count of 100,000 or more, if the case definition, the clinical side, is not fulfilled, there is no reason to give antibiotics. And of course, the practice of giving suppression, low dose suppression for recurrent UTI has very poor evidence to recommend it. The next myth of prophylaxis would be that those situations in which antibiotics are given to avoid hospital readmission. As you all know, if you have a readmission to a hospital from a post-acute care center within 30 days, this is tracked and you are penalized, so to speak, by CMS for excessive numbers of hospital readmission. So people are like trying their best not to readmit patients. And often patients who have vague symptoms like fever by itself with no localized findings of infection or some other vague symptom will be put on antibiotics with a view to this will keep them out of hospital. This is not true. It's simply not. There's no evidence that that actually works, and we don't recommend it. The next myth of prophylaxis is antibiotics given to avoid a bacterial infection following viral illness. This is very common in patients who have bronchitis, which is always viral, always. It starts, and people often, patients and often physicians will say, give me a Z-Pack, for example, to take antibiotics to prevent so-called progression to pneumonia or what they might think might be a bacterial bronchitis supervening above or after the viral bronchitis. This is a really sticky area, like it's wound very tightly in a lot of people's minds. And our objective is to unwind that or free it up so that people can see clearly that there's no reason to give antibiotics in that situation. The one that's related to the pandemic that we're just coming out of now is the large number of patients with COVID-19 infections that are and were being treated with antibiotics to prevent SARS pneumonia, the severe pneumonia, the life-threatening pneumonia that's associated with the SARS infection. But we know now that that pneumonia is not a bacterial pneumonia. Rather, it's a hyaline membrane pneumonitis with hyaline membranes down in the alveoli, not unlike hyaline membrane disease of the newborn, which affects that population. It is very well understood in that population that nobody's given antibiotics to infants with hyaline membrane disease. But for some reason, people think that giving antibiotics in the face of a viral COVID-19 infection will prevent the SARS pneumonia. And that simply is not true. So that's about all I want to say for this little presentation on prophylactic antibiotics. I want to summarize by saying that only evidence-based prophylaxis is recommended. We do not recommend any of the myths that I reviewed, giving antibiotics where there's really no evidence that it's going to work. And remember that antibiotic stewardship goals are still important: to measure antibiotic prescribing, to make visible antibiotic overuse so it can clearly be seen by the prescribers to minimize the misdiagnosis of asymptomatic bacteriuria and other non-infections such as non-pneumonia and non-round wound infection. And lastly, to enhance decision-making of prescribers and nurses. And we're steering here a transition in thinking or mindset about antibiotic prescribing. And also diagnostic stewardship goals, that's the other side of the coin from antibiotic stewardship, is diagnostic stewardship. And the goals there are decreasing unnecessary urine cultures, unnecessary chest x-rays, and in general, unnecessary prescribing of antibiotics to patients who have a round wound or a pressure ulcer. And that's our show for today. Thanks for paying attention, and we're going to do more. Stay tuned.